The broadcast is now starting. All attendees are in listen-only mode.
Welcome, 6 Month Smilers. We're excited that you're here for this advanced level webinar. We actually reached deep into our repository of webinars to pull some of our best of techniques, and this is the first one of those series of best of webinars. So hopefully you'll see some things that you already know, and in addition to, you'll probably get experience into something that you may not have thought of already. Either way, we hope that you find this 90-minute session full of information that helps you help your patients do get better smiles and helps you do more 6 month smiles as well. My name is Omer Ahmed. With me is also Stephen Contreras, Esther Adame, and Becky Butler, who are part of the 6 month smile team. And presenting this webinar is our very esteemed and our honored guest, if you should, I should say so, or our clinical instructor, Dr. Brooks Haney. Dr. Haney, I do want to thank you from the bottom of my heart for helping us organize these series. We know how much people appreciate this, and certainly we also know how much time it takes to put this together. And let me also express my gratitude to you for all that you do for 6 month smiles and for your patients as well. I'd like to go through a little bit of bio of Dr. Haney. He is a native Texan, was born and raised in Dallas, Texas. He received his bachelor's degree from SMU, which is Southern Methodist University, and a doctor of dental surgery from Baylor College of Dentistry. He's a member of numerous local, state, and national dental organizations, including the American Academy of Cosmetic Dentistry, Dallas County Dental Society, the American Dental Association, and the Texas Dental Association. He has served 3 terms as the representative on the Dallas County Peer Review Board and is also recently been the adjunct professor at Village College of Dentistry in operative dentistry. He's also achieved the very prestigious status of Good Fellow with the Dallas County Dental Society. Dr. Haney has also completed the curriculum at the prestigious L.D. Pankey Institute for Advanced Dental Education. He likes being busy, that much we know. Not only does he have a very busy practice, but he's also always looking at continuing education and advancing his knowledge of dentistry and learning more about advanced concepts. He's taking courses at the Dawson Center for Advanced Dental Study with Dr. Coyce. His staff has training in TMJ therapies, sleep apnea treatment, 6 month smiles, advanced bleaching, and I think most recently also implants and sedative dentistry. He's made a lot of presentations, numerous presentations to local dental study clubs, as well as spoken at the AACD. He is our clinical director and clinical instructor for 6 month smiles. Personally, Dr. Haney and his wife Susan have 2 children, Anna and Chris. They are lifelong members of the Spring Valley United Methodist Church in Richardson, Texas. Um, a, Dr. Haney also has a passion for baseball and is a trustee with the Dallas Boys Baseball Incorporated. He's taught baseball for years. He enjoys coaching, doing a lot of sports, fishing, golfing, and assuming he has some time left spending time with family and friends. So with that introduction, I do want to turn over the presentation to Dr. Haney. It's going to be an exciting 90 minutes a seminar for you. Please make it engaging. You are going to be on mute because we have several, over 100 people in attendance. And but you can type your questions in the questions portion of this webinar, and we'll answer these questions. We'll type them up as well as interrupt Dr. Haney if we need to answer some of your more important questions. Do hang in here for the entire 90-minute session to get your CE, and for those folks in the UK, your CPD for this event. Also, at the end of this session, we have something that's very, very exciting for you. This is the kickoff of our Black Friday at 6 month smiles, and we have some very interesting, exciting specials for you. You don't want to miss that. So stay with us for the next 90 minutes. It's going to be a lot of fun. Look forward to coming back to you at the end of this. And Dr. Haney, the floor is yours.
Thank you, Mayor. Thank you for that introduction. Thank you very much. That was too much, for sure. So what I want to do, I want to make this as informative as I can for you. You've taken time out of your day, each one of you, to be here to watch the webinar, and I don't want to fill the webinar with information that won't help you. I want it to be something that you can take back with you and use in your operatory today, tomorrow, so that you know these advanced level webinars are done for you. You know, they're done to help you and to reach out to the questions that we get most often on the forum. If you're not using the forum, we'd like for you to use the forum. The forum is a great place to post your questions, and it's a great resource if you have questions to maybe try to find a case that's been similar to yours. We answer questions on the forum all the time, and from answering questions on the forum for doctors and helping them by giving them a response, we learn what some of the things that bother some of the doctors are, things that people have trouble with. The L1 course is packed full of information, and it's all you can take in 2 days. And there's so much there that you really don't even grasp. It's like the first time you see a movie, you don't really get all the details. Second time you start to pick up the details. So some people re-attend the L1 course, or they advance to the L2 course to try to expand their knowledge and try to be more and more comfortable. So we're gonna do our best. I'm gonna do my best to help you to be as comfortable as possible with all these techniques. So today, our agenda, we're going to be talking about crowding and rotations. Okay, we're going to basically, I don't have time to talk about every type of crowding, like there's crowding where we have extractions, crowding where there's non-extractions. We're talking really more about teeth that are crowded and badly rotated, and some of the tips and tricks to deal with those rotations. Okay, I'm going to go through that and then spend about almost half the time going through that, and then we're going to talk about open bites a little bit. We're getting a lot of questions about what causes open bites during treatment, and then also if you have a patient you start with and you want to correct an open bite, how do you do it? And then lastly, we're going to talk about cross bites a little bit, some anterior and posterior cross bites. And then, like Umair was sharing with you, there's a really neat surprise at the very end. Of course, that's always the trick, to hold it out to the very end where your CE credits are, but also there's going to be this pretty interesting video that we're going to play for you, or a kind of a viewer that you'll see near the end of the presentation. So hang on for that for sure. So like I say, stay to the end. You'll get a sneak peek of the new Confidex Ortho Viewer. It's pretty incredible. I've gotten to look at it and play with it, and I can't wait to show it to my patients. So plus that and the Black Friday deals that you'll hear about at the very end of the presentation. So hang tight and we'll get to that. So first of all, does this case intimidate? Well, most of you would look at that and say, no, of course that doesn't intimidate me. I know I can do that with 6-month smiles. I know I can do that faster and better with 6-month smiles than I can in any other system. But then when you look at the upper arch, not the best pictures in the world. I took these off the forum. This is not my photography, but off the upper arch, now you see that maybe it is a little bit intimidating when you see the blocked out upper canine. Again, this speaks a little bit to photography, because I'm going to be talking about photography. This is not a presentation about photography, but photography is real important to the progression and understanding what you need to do with your cases. I diagnose so much from photography, but now we can see that there's a little canine up there in this photo, even though the lip's in the way. That's not impacted, but it's a very high canine. So now we've got a problem where we've got crossbite, and we've got both anterior and posterior crossbite. We've got the lateral incisor and the premolars in crossbite, and we've got a high canine. And so these type of cases sometimes intimidate people. And so those are kind of things that we want to clear up for you when we do the ALWs, the advanced level webinars, or also to clear up for you when we do the level 2 course, the level 2 training. And I think there's a little special about the level 2 course towards the very end of the presentation today. So back to photography for just a minute. And I'm not going to bore you with photography, but I would recommend that you do the following. This is what I do with my staff. If the picture is not the way it should be, they have to retake it. They don't want to retake it. They don't want to be late. They don't want to run behind. They don't want to have to retake the photos. But if the lips are not out of the way, if we're not looking at the teeth in the direction we should, and we want the photos retaken. For one thing, it's a great way to diagnose, as I'll show you, but also it's great record keeping, and you'll be proud of your photos, and you'll build up your own number of cases that you've done and that you can show to other patients, and you'll be proud that you have that photography, not just for record keeping. Okay, so you want to make sure to get the lip out of the way and look down 90 degrees. So what you want to look here at this photo, it's a good photo. It doesn't get the cheek out of the way all the way back to the second molar, but it's still a good upper occlusal photo because you're looking down 90 degrees on the occlusal surface of the teeth, and the lip is out of the way. So what you can see, I think you can see my little pointer there. You can see the wire, and you can see if the wire is fully engaged in the brackets, and you can see how the brackets are related to the teeth. You have to have that angle in order to see it. Here's the lower picture, same thing. That we're looking down right 90 degrees on top of the teeth, and we can see the bracket in relationship to the incisal edge. We can see the wire, and the lip is out of the way. All right. So that all has to do with basically the angle of incidence, okay, of your camera. You know, what you want to do is make sure that you're looking the green line, looking down the long axis of the tooth, not the red line where you're just cutting across it. You absolutely want to be looking straight down the side of the tooth. Okay, now I joke about this. I said Batman. It's kind of like Batman, or maybe I should be careful. It could be Batwoman. I'm not sure if that's a man or a woman. I think that's a man. But anyway, whether it's Batman or Batwoman, it's like you're standing on the side of the building and you're looking down the building. Okay, just like that. That's how you want to be able to look at your upper and lower occlusal views. And that's what's going to help you the most with rotational correction. That's the first topic we're covering, is rotational correction. So your photography is crucial. So secondly, here's decent photography. The lip isn't really out of the way, but the wire is not in place. When you take your photography, especially your progress photos, make sure to get the lip out of the way, but take your progress photos with the wire in place. Remember, the driving force behind 6-month smiles is the memory, the shaped memory of the nickel titanium wire. So we're looking for deflection in the wire. If the wire is passive, if the wire is not deflected in some way, then the wire is not moving the teeth. Something else has to move the teeth. There are doctors who will spend months with the wire not deflected, expecting something to happen. If the wire is passive, it's just going to stay right where it is. If you want the teeth to move, the wire needs to deflect, and we'll talk about that in some of the slides coming ahead. So this was a forum post. I think this was last week, and this is just I just picked one real fast. I could have picked 1,000 of them, but I just happened to pick one. This may not even be the best one. So the doctor posted the question basically saying, I have a problem with the derotation of the upper right and left canines. So this is the kind of questions we get on the forum. 2 weeks ago, I put lingual buttons on teeth on the upper right 2 to the upper right 3, the upper left 2 to the upper left 3 with short power chain. I long tied the front teeth so they wouldn't move. A long tie is a great way to, of course, to brace teeth together, lock them together to create an anchor. My question is, how long do you think it should be? It says thing, but how long do you think it should take to derotate those canines? And do you have any advice on how to finish the case? So this is the kind of picture that we'll get sometimes on the forum, and this is okay. It's just not great. I mean, this is a lot better than some of the pictures that we get on the forum. And what the doctor's wanting to do is pull the distal aspect of both canine around. They want to move the distal of each canine around to the lingual, to the palatal. So my point is, on the forum, we'll give advice, but almost always it's so much more critical and better advice if we have really good photography. Now, if you look at this case closely, you'll see here, and looking at the photography, that the wire is not down into the bracket slot. I hope you all see that and grasp what that means, because this is absolutely crucial with 6-month smiles. See how the wire disappears down into the bracket slot here on the upper right central and the upper left central? See how the wire doesn't disappear down into the bracket here on the upper left canine? Because the wire is not down into the bracket, the wire isn't deflected the way it would be. The quick tie, I think the bracket is actually a little broken here. And when the quick tie does not hold the wire down into the bracket slot, then the wire is not deflected. So we have a passive wire. And with a passive wire, we're not going to get any movement because of the wire. So when we look up close again, we can see that the wire is sticking out of the bracket slot here, that the quick tie is not holding it down in like it should. So we're going to talk about how to make sure that we get that wire to deflect so we get those kind of changes that we want. Okay, here's another one that was very similar on the board on the forum. Again, you can see the level of photography is not real good. We're pretty far away. That's not a retracted view with a mirror in place. That's a straight on view. And the doctor's concern is the fact that the canine, either canine, won't derotate. And if you look closely, and you can barely see, it's kind of fuzzy, you can see that the wire is coming out of the bracket slot. I'm going to show you some in more detail, but I want you to see what bad photography does to us sometimes. The photography is not good enough. It just so happens if you blow that up a little bit, you'll see, and I'm putting some lines on here for you, you'll see that the wire is going one direction and the incisal edge of the canine is going another. So the wire has popped out of the bracket slot. It's not held down in there. So when you have rotated teeth, you need quick ties. Please understand the best way to correct rotations is with light wire, not large wire. There's no goal in my office to try to get to that 018 wire. So often I see on the forum people say, well, I'm already in the 018 wire, but the teeth aren't derotated. Well, the point is to get the teeth derotated with the lighter wire. The lighter the wire, the 014 wire and even the 016, the easier they are to engage fully down into the bracket slot with quick ties. And then you can get the rotational correction that you want. So again, this is a great image of the teeth. It's a great view. We're looking right down on top of rotated teeth, and that's a beautiful view. In a preoperative view, you can see a lot in that picture because you can see the level of rotation. Here's another view. It's not a bad view. It's a pretty good camera angle. The lip's not out all the way, but there's no wire in place. So you really can't tell what's going on with your case and your rotations unless your wire is in place when you take your photography. So here's one where the wire is in place, but the lip's in the way. We can see that we got a problem here with one of the lateral incisors, but we can't tell a lot about what's happened to its bracket out there because the lip's covering the bracket. So do your very best with your photography to get 90-degree angles and to get the lip out of the way. So now that we've covered that part, so we can look at our photography, how do you get off to a good start? There's two ways to getting off to a good start, and that good start is going to help you correct rotations. One is proper bracket positioning, which I'm going to call delivery. And the other one is going to be making sure you get 100% full slot engagement of your wire into the bracket slot. Okay, normally that's not going to occur with a simple donut or elastomeric tie. That's going to require a quick tie when you have a tooth that's rotated. So first part though is proper bracket positioning, delivery. And what you may be thinking to yourself, well, that's pretty easy. 6 Month Smiles does Confidex, and Confidex does a wonderful job of creating delivery trays that put the brackets into the proper position. And that is absolutely true. But then there's the part the role we play in it. We have to deliver those trays. And if you ever notice where you have the most trouble with rotational correction, it's usually in the upper or lower anterior, specifically the lower anterior. And the reason is because when those teeth are rotated, sometimes people put two lower trays in at the same time, and the trays bump in that area and they don't get fully seated. So the Confidex, the trays that are made for your delivery trays are made with the brackets in the right position, but we don't get them there because we don't seat the trays properly. So what I recommend is that number one, you ensure that the trays are fully seated and make sure to apply vertical and lingual pressure. When you have a rotated tooth, there's going to be a natural tendency of the tray to want to pull away from that tooth. And if it does, it's going to change the orientation of your bracket to the facial of that tooth. What that would do is that would put more resin under one side of the bracket than the other. You want to push in to where that bracket is flush with that tooth, and there's an equal amount of resin underneath the bracket all the way across. So it reflects what the tooth is doing. So put pressure both vertically and lingually on your delivery trays when you seat them. And the area where this is the most important is in the midline and where teeth are the most rotated. So let's take a look at an example of improper bracket positioning. Okay, this was on the forum, and you see the problem on the lower arch. You see that the doctor or the assistant, the staff on one side, starting with the left central, got the tray seated completely, And so the brackets are down where they belong. But on the right side, the entire lineup, the entire from the right central all the way back, the tray didn't get pushed down completely. Probably because either two trays were in at once and they bumped into each other, or because the doctors just didn't consciously think about putting vertical pressure on those trays when seating. So now you see the problem. We've got the brackets at one level on one side and another level on the other. Well, the Confidex trays weren't made that way. Confidex puts them in the perfect position. This is where we let down. And now the entire case is going to be affected by the fact that we didn't get proper bracket positioning. Let's look at this case. This one I think it really shows you what I want to talk about the most. Look at the upper centrals. Okay, the doctor would like to get these centrals to derotate. Can you see with me, if I put my arrow right there, can you see that the amount of resin over here on this side, on the distal of that central, is less than the amount of resin over here? The resin's not uniform. So if we look at the incisal edge, here's the incisal edge going this way, and the bracket's going that way. If I put little lines in there like that, see what's happened? That because the tray was not pushed in towards the lingual, the bracket orientation has changed. That bracket should be parallel to that incisal edge. Those two red lines should be parallel. If they were, then the wire would bend in more and the tooth would be corrected. But if you look at my little yellow lines, you can see that there's a lot more resin under the mesial side of the bracket than the distal side. And why did that occur there? Because the teeth are rotated, and at the midline especially. So when you're placing your delivery trays, make sure and push towards the palatal or towards the lingual so you get a uniform amount of resin underneath the bracket. You don't want more resin underneath one side of the bracket than the other, otherwise it won't be parallel to that incisal edge. Okay. The next thing is, that's number one, make sure you get your delivery tray seated. And the second one is making sure you get full slot engagement. Okay, how do you get full slot engagement? Well, the best way to do that is using quick ties and light wire. All right, if the wire lays passively into the bracket and you can put a donut around it, great. You do not need a donut and a quick tie on the same tooth. All right, you can do one or the other. All right, you don't have to have both, but sometimes we'll see that. But anytime you've got a tooth that's rotated or an area where the wire does not want to stay down in the slot, definitely use the quick ties. Now think about it. If this is an 014 wire, it's pretty easy for the quick tie, which is an 012 wire, for the quick tie to hold the wire when you twist it down to hold it down into the bracket slot. If this was an 018 arch wire, it's so rigid, it's probably not going to pull down into the bracket slot. So it's not going to deflect as much. So the 018 wire isn't nearly as good for correcting rotations. I know you think it's larger and stronger and it ought to move teeth better, but that's not true. Teeth respond better to light forces, and the 014 wire is your friend, trust me, for correcting rotation. So do your very best to stick with that 014 wire as long as you can. And you can deflect the 016 wire as well, but the 014 wire is the best for correcting rotations. So take a look at this one. You can see that the doctor used a quick tie here. This is off the forum. You can see that a doctor used the quick tie there, and on the forum the doctor said, hey, I've got a quick tie in, I've done everything like I'm supposed to, and the teeth are not rounding out and the arch is not getting straight. Well, most of you, hopefully, that are on the presentation today that are listening, you can see that the wire is going this direction and the incisal edge is going this direction. In no way is the wire parallel to the incisal edge. If the doctor could get this wire down into the bracket slot, if it goes down into the slot, then the wire bends in on this side. Then when the wire rebounds, the tooth goes along for the ride and everything's nice and straight. So the problem may be it's tight in here and the doctor can't do it. I'll show you how to do it. It may be that the wire is too big. The bigger the wire, the harder it is it's going to be to pull down in there. Okay, so if this bracket appears to be in a good position, it's not bad bracket positioning, but it's bad slot engagement. You want that wire to be fully engaged into that bracket slot. All right, so you'll see this again. Here's a quick tie that's on a bracket, and there's the bracket, and here's the wire. You can see that the wire is only engaged into the slot right on the corner. The one on the other side, the quick tie, is holding the wire down in the bracket slot. Let me back that up. Here we go. It's holding the wire down in the bracket slot. On this side, the wire is not down into the bracket slot. So make sure when you have rotated teeth that you deliver the trays properly, and that you start with light wires and you get the wire down into the bracket slot. So how do you do that? How do you get that wire down into that slot? Well, the best way to do it is to take your ligature director, your wire director, and push in on the wire. Don't just put a quick tie on it. Put your wire director on it and push in. It may be a little uncomfortable to push in on the tooth, but it's not that big of a deal for the patient. You push in towards the lingual, so you're pushing the wire down into that slot while you put the quick tie around the tooth. You twist the quick tie down, and as you twist the quick tie down, of course, you'll tighten the wire up, cinch it up nice and tight, and the wire will then have that deflection or bend you need in order to be able to make the correction that you want. So same thing here. You can see the red line is the incisal edge of the lateral incisor, excuse me, central incisor. And you see the green line is pretty much the direction of the wire. So the wire is not being held down in the bracket slot. The reason you take the photography and for 90 degrees is you're trying to determine, is it my wire that's not down into my slot correctly, or is it my bracket that's not positioned correctly? Because one or the other is the reason your case is not correcting. It's either that your bracket doesn't have a uniform amount of resin underneath it. There'll be varying amounts of resin. It won't be even across. Or that one bracket will have a lot more resin underneath it than the adjacent brackets. It needs to be uniform, the same amount of resin under each bracket. Or it'll be that the wire is not engaged into the bracket slot. So you know now to take the pictures so you can see this angle. You know that what you're looking for. You know you're looking to make sure that the bracket is actually parallel to the incisal edge. It's pretty simple. When you're looking at it from 90 degrees, you want the bracket parallel the incisal edge. If it's not, then you really need to reposition it, or I'll show you a trick. So if you want to reposition the bracket to make sure you have it the amount of resin uniform, that's great. Reposition it. If that's not the problem, if the problem is that the wire is not held down into the bracket slot, then put your ligature director, your wire director here, push to the lingual, put a quick tie around it, and tie it down. And make sure you're using light wire. Don't be in a hurry to jump in wire sizes. All right. Here's another example. You can see the incisal edge of the lateral incisor. I marked that for you in red. And you can see that the doctor has got what appears to be a quick tie in, and everything seems to be right to the doctor. But if we look at the wire, we'll see that the wire is not at all parallel to the incisal edge. All right. So there's a problem. In this case, there's more resin under the mesial side than there is the distal side. So the orientation is not right. The wire is actually engaged into the bracket slot. The bracket slot just not parallel to the incisal edge. So you're not going to get the kind of derotation you want. Here on the other side, you can see the wire is tied in properly. So that tooth is going to begin to derotate over the next month because of deflection in the wire. If you look at your wire and your wire is passive, there's not going to be any movement. Don't expect movement. You've got to have a deflection in your wire to create some movement of the tooth. See the way I drew a little black line in there for you, trying to show you how you want the wire to deflect. And if the wire were to bend in like that black line over the next week or two, it's going to derotate that tooth as long as you provided the IPR for that to occur. So what do you do if there's not enough room? What do you do if there's not enough room? You can't, I've got a clear it here, because if they put a bracket on here, they felt like they couldn't get a wire in, or that the brackets are so close to each other, you can't get your wire director down in between the teeth. What do you do when teeth are real close together like that? All right. One thing you can do is put the bracket off center. Now, I eliminated a slide here that would show you this, but this bracket has been placed off center. If you put this bracket in the center of this tooth, and you put this bracket in the center of this tooth, the two brackets are going to bump together. And there's no way you're going to get anything down in between these teeth to derotate those two teeth. Now, some of you know that you could put lingual buttons, one here on the distal of one ladder and one on the other, and on lower teeth, connect those with one link of continuous power chain to start the derotation. You could also even run a power chain from one side to the other side, from this side back or from the other side back, to try to gain some derotation. But as far as being able to bring the wire down into the bracket slots, what you can do and look for wire deflection. And don't be in a hurry to advance to the larger sizes of wire. There's just no good reason to do it. Okay, there's no advantage to getting to that 018 wire in some hurry. There's a slide in the 01 course that shows 2 months with the 014, 2 months with the 016, and 2 months with the 018. For me, I don't follow that at all. I'll go 2-3 months with the 014 and 2 or 3 months with the 016, and sometimes never even use the 018. So I wouldn't be in any big hurry. Make your corrections with your quick ties using the lighter wire. So you'll hear about floss engagement. Sometimes on the forum when you post a question and the doctors will say, I cannot get the wire down into the slot. Just can't do it. I can't push it with my wire director. There's no room. I can't hold it down in there. And we will make a suggestion of using floss engagement. And if you're on the forum, we give you a link, and the link will show you step by step how to do the following. And I'm just going to show a few pictures here I took in my office one day where we've got a tooth that we could do this with a ligature director. I could push in on that wire with a ligature director, get a quick tie around this tooth and tie it. You can see that the bracket is parallel to the incisal edge. So the key to derotation here is getting the wire down into the bracket slot and making it stay there. A donut is not going to hold it down in there. So one option you have when teeth are really close together, if you don't feel like you can get the wire down into the slot completely because you're either your ligature director, your wire director, when you push in on it gets in the way and you don't feel like you have space, is just wrap floss around the wire. Just wrap floss around the wire and run it through the proximal contact. Then I did this all by myself, which my hands didn't take two people. Okay. And then I'm holding, all right, to the lingual with one hand and twisting with the other hand. So you can see what I've got here. I've got floss around the wire. I'm pulling towards the lingual with my floss, pulling the wire down into the slot, while at the same time I've wrapped the quick tie around the bracket, and I'm going to twist the quick tie down. And then when I'm finished, it's going to look like this. It'll have the wire down in, but it would have the quick tie attached to it. But you can see what it looks like when I pull the wire down into the slot. All right, and there it is finished. Now, at the same time, I want you to grasp that because that's a really good technique for getting that wire to deflect. Can you see now how the wire comes in and it bends in and it goes back out? So now the wire is no longer passive, it's active. This part of the wire is going to recover and rebound to the facial. And when it does, it's going to take this tooth and move it to the facial, and it's going to derotate that incisor. Well, on the same slide, I decided to show you the other technique. When the bracket's not in perfect position and you don't want to reposition it, what can you do? This is when I talk about deepening bracket slots, and I talk about this a lot on the forum. Here we are with this other incisor. Here we got the lateral incisor, and we can see the bracket. The angulation of the bracket is the black. We can see the angle of the incisal edge is green. So the bracket really doesn't quite reflect the angle of the incisal edge. The bracket should be more like this upper green line. So I've either got to take that bracket off and reposition it so that it is parallel to the incisal edge, or I can just deepen the bracket slot and change the shape of the bracket. So what I do is I pull the wire out with my wire directors, pull it out of the slot, hold it off the side, and then I take a diamond and I cut at the angle I want this to be, at the angle of the incisal edge. I just take my diamond and deepen the slot on that side, so that now I take a flowable rotation bump and put it on the opposite side. So now if you look at the wire, you'll see that the wire is now parallel to the incisal edge. With the bump there and deepening this side, putting a quick tie around it, now my wire is going this direction, is parallel to the incisal edge. The wire now being deflected, then this tooth will derotate and I'll get the corrections that I want. So use those flowable rotation bumps, and don't be afraid to deepen the side of a bracket slot. I do that quite often, especially when I'm near the end of a case, I'm finishing a case. I don't do it very early. I don't do it very often, very early on in treatment. I do it much later in treatment. But you can see what a difference that makes. We've got a very active wire there now. It's going to help derotate those incisors. We're all familiar with the flowable rotation bump. I thought I had invented the flowable rotation bump when I took my L1 course. I didn't remember it. And I was treating cases and love doing 6-month smiles. We do a lot of it. My staff loves it. And one day I thought, well, what if I put a bump in that slot? And I saw what it did to the wire, and I thought, that's fantastic. And then I looked back in my level 1 book and saw that somebody taught me that, and I'd forgotten it. So a lot of things you're taught in L1 you just forget. And this was one of them. Make sure you use those flowable rotation bumps. What happens here, when the bump's on the mesial, it's going to push the mesial of the tooth to the lingual. If the bump was on the distal, it would push the distal of the tooth to the lingual. If I wanted to move the entire tooth to the lingual, I could fill the entire bracket slot or put a bump right in the middle. And then the wire would bump out right in the middle and move the entire tooth to the lingual. So those are wonderful. Now, this is something you're not familiar with. We teach this in the L2 course. The L2 course is chock full of information. It's a busy 16 hours of study. We work hard in the L2 course. There's a lot to cover. But this is called a flowable rotation wedge. Sometimes you just need more. You just need like a wider bracket. And essentially, that's just what this forms. We just take composite, add it to the side of a tooth, so that we can kind of bump the wire out a little bit more on one side of the tooth, so we can kind of get a little bit more control of the tooth. I use these flowable rotation wedges quite often near the end of treatment when I want to get that little extra tweak that the bracket won't quite do for me. I haven't started talking about pop bends. Well, I use pop bends the most, but these flowable rotation wedges are pretty cool, and you can kind of see how they work. This is bonded to the enamel. I actually etch and bond this to the enamel, and then, of course, remove it later. But we build it out as much as we want to get the wire to deflect in an area where we'd like to put a little more lingual pressure on the tooth on one side. That's called the flowable rotation wedge. So in the L2 course, one of the things that we go over for quite a while are the 8 ways to correct rotations. So if you're having trouble correcting a rotated tooth, don't give up. Certainly share it on the forum, or use your knowledge, because there are 8 ways to correct rotations. First of all, remember good photography, 014 wires, and quick ties. Make sure your brackets are positioned the way they should be. Okay, you can alter a bracket position. Okay, we already talked about that, moving a bracket one way or the other, and I'll show you that on a slide in just a minute. And we've talked about the flowable rotation wedges and the flowable rotation bumps. All right, making sure we have wire deflection. All right, we just deepened a bracket slot. Okay, that's another way. But we also can derotate teeth or rotate teeth with pop bends, power chains, and open coil springs. And you know what? You can combine these techniques. You can do more than one thing. You don't have to just do one technique at a time. So oftentimes I'll combine 2 or 3 of these techniques to get a tooth to derotate. So pop bends, rotational bends. One of the things that we cover heavily in the L2 course is making sure everybody leaves there knowing how to use their pop pliers. With the pop pliers, you can make nice rotational bends. All right, a rotational bend like this, when the wire comes along and then the wire bends in, that's going to push the mesial of this tooth to the lingual. All right, if this part of the wire comes along and then goes out, that's going to push the distal part of that tooth to the facial. So pop bends are a great way to derotate teeth. So if you're not using pop bends, or if you haven't used pop bends, they're great. I typically don't use pop bends, not always, but typically don't use pop bends until I'm in my final wire size or next to the last wire size. In other words, if I'm going to finish the case in an 018 wire, I'm probably not going to make pop bends until I'm in that 018 wire. Sometimes I will make it when I'm in the 016, or maybe I'm finishing the case with an 016. I don't use the 014 wire much for pop bends, but I use the pop bends typically towards the end of the case. Now, let's talk about altered bracket position for just a second. This bracket on the central incisor is in the center of the tooth. That's right where it belongs. But let's say this tooth was rotated more. If you move brackets off center, okay, and when you move a bracket a millimeter to the left or a millimeter to the right, it enhances the action of the wire. Because if you move the bracket one way or the other, then the bracket's going to go with the curvature of the tooth. For instance, with this bracket on the lateral incisor, if you move this bracket half millimeter to the distal, with the curvature of the tooth, the bracket's going to start bending in more to the lingual. It's going to angle in. Well, that's what you want. That's what you want. By moving the bracket one way or the other in altered bracket position, you can change the orientation of the bracket to the tooth in a way that is helpful. Here's another pop bend for rotation. You certainly can try to derotate teeth with pop bends. It's a great technique to do. I use it quite a bit. Power chains. Remember, with power chains, that there's a rotational pull on the most terminal tooth. So if you look at a power chain and you run a power chain from one tooth to another tooth, the distal aspect of each tooth is going to want to rotate around to the facial. So look at the anchorage for your power chain and take the tooth that you're wanting to rotate and putting it on the terminal end of a power chain. We do that a lot with the two linker, okay, on molars. And when we do that, it's because the molars don't rotate. So we use this. If we wanted to derotate that premolar, I can think of a lot of ways we can derotate it. We can all those ways we just listed. But I can derotate that premolar simply by putting a power chain around the molar, a two-link power chain, and going around the bracket of the premolar. I like for the power chain to go all over the top and bottom, but even if it just goes over that wing, it's going to exert a rotational force on that premolar that's going to take the mesial part of that premolar and pull it to the facial. The molar is not going to tend to want to rotate. So look at the anchorage, because it is possible that both teeth would rotate. If the terminal tooth on each end were both incisors, then both teeth on the distal would rotate towards the facial. Open coil springs. How do open coil springs rotate teeth? Well, right here, you have an active open coil spring and two passive open coil springs. And I know that's a little confusing. Why are these passive springs here? But what I want you to concentrate on is the open coil spring here. This open coil spring is going to push, okay? It's going to try to unwind. It's going to push. It's going to try to push this premolar this direction, the bracket this direction, which would rotate the premolar. The doctor in this case is wanting to rotate the canine, the mesial of the canine to the lingual. So it's going to, as we look at it, the doctor's wanting to rotate that canine in a clockwise direction. So this open coil spring is pushing it in that direction. All right, so the open coil spring can be used for rotational correction. The reason for these non-compressed open coil springs is so that we don't get rotation of this tooth. We're only wanting to rotate the canine. So this keeps the premolar from rotating while we put pressure on the molar, on the canine. So open coil springs are great. So again, sometimes you're just unable to position a bracket. This is Catherine. Catherine's a sweet lady, great lady. She moved to Florida. Let me back that up. She moved to Florida on me, but she came in and had this really, really badly rotated lateral incisor. So what are you going to tell the laboratory? What are you going to tell Confidence you want to do with that lateral incisor? Well, a clearlet is not going to help you here. And obviously, there's no place to put a bracket on the facial of the tooth. So what I asked the laboratory to do was just put a bracket wherever they could. I said, put it right out here on the mesial of the tooth. I just need a bracket. I need something I can grab a hold of where I can move that tooth. So that's exactly what I asked them for. I asked them for a bracket right on the side of that lateral incisor. All right. And then I used my open coil springs for rotation. So we back up. here I'm wanting to use the open coil spring, first of all, to create space here, all right, for my lateral incisor, but also for rotational purposes. So here we are. We can see the open coil spring between the canine and the lateral, and what it's doing is creating some space between the two, and it's rotating it lateral at the same time. So I'm using a rotational and space creation technique of my open coil spring. And sometimes you get some unwanted movement from this, and I like to show this and show you things that will happen and how to correct it. It's okay to get some unwanted movement, because with 6-month smiles, we can correct things ourselves very quickly. We don't have to send them back in for mid-course corrections or anything like that. So here we can see that my open coil spring has clearly created space for this lateral incisor now. And it's clearly started to rotate that lateral incisor where I have access now to put a bracket on the facial. But one of the negatives is that it pushed the distal half of the central incisor out facially. So I got some rotation I didn't want there. Now I could have prevented that with a long tie. I didn't know to at the time. This was back earlier in my career with 6-month smiles, but I also knew it's real easy to rotate that back. So what I did was I attached a bracket to the lateral, and then I used power chain to close everything back up. And as I close everything back up, I got my lateral back in position, close the space down. And there she was immediately after we removed her braces. I hadn't had a chance to whiten her teeth or anything. But you can see a tooth that you'd wonder how in the world could we derotate it. We were able to derotate it quickly. And no, I did not do those crowns back there. So before you say something about those margins. Okay, so rotations, just to kind of sum up rotations, think about what we've got. We've got a lot of tools to correct rotations. We can push on the tooth with an open coil spring. We can pull on the tooth with a power chain. We can use a pop bend to change the orientation of the wire. Pop bends are wonderful. But the most important thing is that we have to provide the IPR to have space for rotation. We have to get the wire to deflect. We need to use light wires. We need to use quick ties, okay? And don't be afraid to reposition that bracket. Use that floss technique if you need to engage that wire into the bracket slot. That floss technique I use quite a bit. We use it this week on a patient. So I use it quite a bit when we have some crowding where we can't use our ligature director. All right, next step. I want to get into crossbites. I'm going to kind of change course. So if you have questions, type them up for Umair so that he can come back and ask me towards the end. We'll get maybe have time for some questions. I'm going to get into crossbites for you now, though. So there are lots of different types of crossbites, as you can see in the picture. There's bilateral crossbites, there's unilateral crossbites, there's mixed crossbites where you have anterior and posterior crossbites, and there are just anterior crossbites. And you know, the thing about crossbites, you do not have to address them if the patient's not interested in addressing them. If you're not comfortable addressing it, and the patient has another cosmetic concern and they don't want to address their crossbite, that doesn't mean that you can't treat the case. If the patient doesn't want to treat their crossbite, you do not have to treat it. I wouldn't force them into doing that. It's a job to correct a crossbite. I prefer to do it, and if it's not part of the patient's chief complaint, or if it's not something you want to do, 6-month smiles will plan the case for you without correcting the crossbite. But if you want to correct the crossbite, we want to talk about how to do so. So, you know, here's a crossbite before. Okay, you can see the crossbite very well there on the upper canine, and we can correct that. We can flip that right over and correct the crossbite, as you can see in the following photos. It's pretty easy to do, correcting crossbites. So we're going to talk about the protocol for doing that. First of all, there's the appropriate placement of bite guards. For correcting crossbites, we're almost always going to use second molar bite guards. Well, all the doctors now have the beauty of using Confidex, and Confidex is going to tell you where your place your bite guards, and they're going to tell you to place your bite guards on second molars. You have to create space for that tooth that's in crossbite to be able to slide over from the crossbite position into the normal position in the alignment. So you have to use second molar bite guards to do that. Now, the two-stage bite guard strategy is, what if you have someone that has deep bite and crossbite? Well, we know, hopefully you know, we correct deep bites with anterior bite guards and posterior box elastics. Well, if a patient has a deep bite and a crossbite, what do we do? What order do we go in? What we do is we correct the crossbite first, and then we correct the deep bite. So what we do is we use a two-stage bite guard strategy. We start with second molar bite guards, clear the crossbite. Then once the crossbite's corrected, we take off the second molar bite guards, put anterior bite guards on, and then start with our posterior box elastics. All right. And we use all these tricks to correct crossbites: open coil springs, clearlets, elastic thread, lingual buttons and elastics, and even the slingshot technique. And I'll show you the slingshot technique. Hang on for that one. If you haven't seen that or done that, it's worth seeing. So I decided to pull a case that we showed a few years ago, and this is being a best of case of another doctor rather than showing my own cases, because I don't want you to think that it's just the instructors that do this. I mean, all the providers do these things. And so I chose Dr. Joshi's patient, Bernice, and I wanted to show you what was done in this case, how the case was treated, and to kind of go from there. So the chief complaint is I want to fix my teeth. The patient had declined comprehensive ortho because of the length of treatment. She's not a patient of record, but heard about Dr. Joshi on the internet through advertisements. And this patient's already referred 3 6-month smiles cases since she had completed her treatment. So that's the beauty of having nice photography. These people refer patients to you. So, in following what Dr. Joshi did, you can see here that there's quite a bit of crowding. Some of you may start thinking, boy, extraction, we're going to have to extract. You can see the crossbite of the upper lateral incisor. Upper lateral incisor is really back there. With the amount of crowding on the upper, there's going to be quite a bit of rounding. And for that reason, there's going to be quite a bit of rounding on the lower as well. So that makes it a non-extraction case. But what Dr. Joshi did is exactly what we talked about. Use the open coil spring and the clearlet to create space to bring the lateral incisor into position and get it out of crossbite. Use second molar bite guards, creating a gap there. You can see the second molar bite guards keeping the teeth apart so the bite guard can cross. The best thing about this that Dr. Joshi did was that when the main arch wire, the 014 arch wire, was tied in to the clearlet with an elastic thread, creating a deflection in the wire. So the open coil spring is still active, even though it's got a bend in it. But we've got two things going on. With the bend in the wire, we're going to get some buccal movement, facial movement of the incisor. And with the open coil spring, we're going to rotate. This central is going to rotate around, the canine is going to rotate around, and we're going to create some space for this lateral incisor to come in. Then, of course, we know how to correct the rotation. Our job is to get that lateral incisor out where it goes. So you can see pretty quickly that the open coil spring, even in a month there, had done a pretty good job. And at the end of that, we're getting into 2 months. You can see the lateral incisor is now out where you can put a bracket on it. And then, of course, you can see that rotation I was talking about. See how the central incisor has over-rotated and the canine's rotated. But now the lateral incisor started to move out into position where you won't need the open coil spring anymore. You can take the open coil spring off. And now we want to talk about altered bracket position. When we've got a tooth like this lateral incisor, this lateral incisor would benefit from rotating the bracket in a clockwise direction. The more that, up to about 15 degrees, the more that bracket is rotated in a clockwise direction, the more the arch wire then will rebound and align the root so that it's not at such a canted or tipped angle. So there we are, and just follow along with what Dr. Joshi did. You can see that everything moved right into place. It's starting to look really good. There's a little bit of an overjet problem. You can see there wasn't enough overjet. So Dr. Joshi started doing more IPR on the lower arch. And here we are, more IPR on the lower arch, and started using a power chain to try to retract the lower teeth to create some overjet. Here we are at 5 months. Here we are at 6 months. And the doctor decided to continue with lower arch retraction. You can see the power chain here. And then eventually at 7 months, getting pretty close. The overjet's pretty close to where it should be. There's a pop bend there. You can see an extrusional bend on the two central incisors. Try to bring them down a little bit. And then at the end of treatment, there's the final case after the case was removed. There's overjet. The crossbite's been corrected. I kind of like showing somebody else's case because it's nice for you to see that this happens all over 6-month smiles. We're certainly not the only ones that do this. All of you do this on a daily basis. And there's the patient at completion. So it's a nice case for Dr. Joshi, and I'm sure that Bernice was thrilled with her new smile. I do want to tell you about the power chain slingshot. You may or may not have heard about this in your L1 course, but I want to show it to you. If you have a tooth that's stubborn, it just doesn't want to move. You can't get it to move. Of course, if it's ankylosed, you're not going to get it to move. If it's an implant, it's not going to move. A lot of primary teeth, we don't bracket because they're not going to move or because they may be ankylosed. But if you have a tooth that's not ankylosed and it's just stubborn, you can do a power chain slingshot. And what we've created here with lingual buttons is basically a slingshot approach. In this case, let's say that this premolar here is positioned to the lingual. In this case, let's turn that around. Let's say this was the lower left, and this tooth was positioned to the lingual. We put a lingual button on the premolar, and we run a power chain from the bracket on the molar. And the length of power chain can be any length you want, but just want to make sure you get pressure. You stretch it around, it goes around, catches the lingual button here, and goes all the way back around to this premolar. And what that does, that puts such a powerful force to pull that tooth lingually, or to pull that tooth in the direction the slingshot would shoot it, that it moves that tooth very quickly. Big word of caution, though. Big word of caution. It's powerful. It's going to move the tooth very fast, and you're going to be really happy with the results. But you can get some unwanted movement, some compensatory movement, some compensating movement of adjacent teeth. So probably not going to get much movement of the molar, but you could get some unwanted movement of the premolar. So I tend to long tie the adjacent teeth to hold them in as an anchor before I use a slingshot. This patient was referred to me by a periodontist that's on the state board of dental examiners in the state of Texas. And he said, Brooks, he said, I've been referred to this patient, and they've got this cantilever tooth up here, and they want to have an implant. And he said, I don't like the position of the canine. And I know the reason the doctor referred the patient to me, because he was afraid if he referred to the orthodontist close by that he wouldn't see the patient for a while. But he knew that I could correct this in a short amount of time. So I used the power chain slingshot technique to correct this. This is the canine here. A little crowding here that was easy to correct, but the canine needed to be moved lingually because we don't want the canine to be out here with an implant being placed above. We want that canine to move back into the arch. So what I did was I long tied. You can see my long tie here. I long tied all the teeth distal of the canine from molar to premolar, and I long tied from canine all the way back around to the lateral incisor here. But I did that to keep the lateral incisor from getting unwanted movement. I put lingual buttons on the lateral and on the premolar, and then I ran my power chain out and around like so. So there's what it looks like. My two lingual buttons and my power chain, and you can see the tooth's already in alignment. It didn't take me any time at all. And I was able to straighten the other teeth out with the lady at the same time. And then, of course, those patients become patients for yours quite often. But the periodontist is thrilled to get the patient back real quickly. Everything is wonderful. And so it kind of leads, I'm usually referring to the periodontist. Now we get referrals from the periodontist. So the power chain slingshot is a great thing for correcting a tooth that's out maybe in crossbite or maybe in a scissor bite type situation. We're all familiar with lingual buttons to correct crossbites. If you have a posterior crossbite, we know that we can correct the crossbite by the use of lingual buttons and cross arch elastics. We all do that. One other thing you can do is if you have a second molar and you're correcting a crossbite, there's our second molar bite guard. We can also make our second molar a little fatter. Okay, this is called lateral advantage. What I did here was I added some composite to the second molar. The bite guard's on the second molar, so it's stabilized by the occlusion. So the wire's not going to push the second molar lingually because that's the tooth we're hitting on. But the wire now is going out to quite a bit facial. What that does is that puts some pressure on the molar and both premolars to move in a facial direction. So the beauty of that is that the combination of the lateral advantage of the widened second molar and using the second molar tube in addition to a first molar tube is that the wire now has a wider base, and now It's going to help to widen the arch on the upper. It's not really going to widen the arch. It's going to tip the teeth facially. And so it kind of fills in that buccal corridor, and it can be used to correct the crossbite. That in combination with the lingual buttons and cross arch elastic. So here we are with the lingual buttons that are on those teeth. We've got the lateral advantage here. We've got the extra composite on the second molar. The wire is bending in towards the teeth and then back out to the canine. So the wire is naturally going to rebound to the facial. I've also got the cross arch elastic, not 3 different elastics, just one long elastic. And we'll talk about elastic sizes. And I'm able to use my elastic then to correct that crossbite. So crossbite correction is a lot of fun. And I like to correct crossbites. It is not a hard thing to do. I do think it improves both the aesthetics and the function of teeth. But it's one of those things that you're not required to do. If you don't want to do it, if your patient's not interested in it, then you don't need to address it. But if you want to address it, we're here for you. The last topic I want to hit on that's going to take a little while are understanding and treating open bites. Open bites, we need to know a little bit about the etiology and the contributing factor, because sometimes there are cases we need to refer. Another thing about open bites is when corrected, they tend to relapse. They're one of the spaced cases where you have a lot of spacing. Severely rotated teeth and open bites are the most common relapse cases. So if you have teeth that are really severely rotated, they really want to relapse. Teeth that have large spaces, diastemas, and you're closing and pulling the teeth together, they want to relapse. And open bites like to relapse. So I'm going to show you some tricks to try to prevent them from relapsing before we quit. So there's different types of open bites. There's skeletal and dental. If we see a skeletal open bite, if you're not sure, submit it on the forum. That's what we're there for. We have a number of mentors and instructors that are on the forum. We'll look at your photography, we'll look at your case and help you to determine whether or not it's a case you should be treating as a general dentist or as an orthodontist, because we have a number of orthodontists that are doing 6-month smiles. But whether or not it's a case to treat with 6-month smiles or whether or not it needs a little more comprehensive care. So skeletal versus dental. There's just some things to look for, and I'm going to try to simplify it a little bit. But skeletal is really the people with that long face syndrome. Okay, you'll see that long face. Whereas with dental, you don't necessarily see the long face. They'll have an open bite, but they won't have that long face syndrome because it's not a skeletal situation. So we'll look at the differences between the two. This would be a skeletal open bite. This would not be a good option for us for 6-month smiles. Now, what tells me that it's a skeletal open bite? In simplistic terms, they're not hitting on premolars. Okay, that's one of the simplest ways for me to think of it. The only contacts are on molars. If those premolars aren't in contact, I'm not going to be able to close that open bite down. I might be able to decrease it a little bit, but that's way too far us to close it all the way down. You have to think about what's happening. Look at that tongue. That tongue's coming forward. There's a tongue thrust there. You have to form a seal in front of your mouth in order to swallow. So is that tongue thrusting to make the seal? Is that the reason the tongue thrust? Or did the tongue thrust itself? Was it there first, and did it keep the teeth from coming together? One or the other, we've got a tongue thrust issue. Is the tongue thrusting forward because the airway is blocked? Do we have a blocked airway? Do you have a sleep apnea patient? We have someone that maybe needs mild functional therapy, or maybe some type of CPAP or dental sleep appliance. So skeletal open bites are one that I'll refer. Now, if the patient just insists and they want you to straighten their teeth a little bit, you can do that. You can straighten the teeth a little bit, but you're not going to close the bite all the way down. The skeletal open bites have that long face syndrome. Okay, they won't be hitting on the premolars and canines. And it's just too far. We're not going to be able to close that with 6-month smiles. All right. Whereas the dental open bite, you're going to be a little bit different. You'll see this. The face won't have that long face appearance because it don't have quite that angulation, and they will be hitting on their premolars. So immediately when I see this, I think, yeah, I can help this patient. So definitely try to determine whether you have a skeletal or a dental open bite. And for me, one of the easiest ways to remember is you can read this, copy the slide. This is in the L2 course, but main thing is if you have occlusal contacts on the molars only, then pretty much it's a skeletal open bite case. And when you have contact on the molars and premolars, then it's a better case for you to treat, for us to treat maybe as a dental open bite that we can treat with 6-month smiles. Now, according to Pete Dawson, there's different mechanics or different causes. It could be thumb sucking, could be a child or an adult that as a child was a thumb sucker, or they had lip or tongue habits, tongue thrusting habits. I work with a mild functional therapist sometimes here in Dallas to help our patients to decrease their tongue thrusting. It could be an airway obstruction where they're not getting airway, an inadequate airway or large tonsils or adenoids. If a patient has something like that, they either need a referral to have that examined, or if you have the capability yourself, we do sleep studies in our office. We have the home sleep studies, and we'll check their airway to check for apnea and check their apnea-hypopnea index. So closing down those open bites, how are we going to do it? What do we do to close open bites? Well, certainly consider, like I said, a possible sleep study, a mild functional therapist, or maybe referral to an ENT, because it may have a health issue here more than just a dental issue. It's pretty straightforward, though, to close an anterior open bite. For the most part, we're going to rely on extrusion of teeth. Now, you have to determine, is it right to extrude those teeth? And what I mean by that, if you've got a patient that has a real high lip line and you want to extrude those upper incisors, you have to think about that, because you're going to show more gingival tissue. So make sure the extrusion makes sense. But we're going to allow an extrusion of either the upper or the lower or both teeth. All right. It especially works well in the anterior because incisors have conical roots. All right. And the other thing that we'll talk about towards the end is that retention and lifetime retention is absolutely essential for these open bite cases. So if we ask the laboratory to position brackets a little more gingivally, then the wire is going to deflect a little more gingivally. It rebounds. The wire is going to move the tooth down some for us. Only makes sense. We can also piggyback. Surely everybody online is on the presentation knows about piggybacking to accelerate extrusion. What we use is a stabilization wire. All right, that's 018 wire cut from the center of the wire, and I'm going to show you what I mean by cut from the center of the wire. And then we piggyback the principal wire, the 014 or the 016 or an 018, but typically we piggyback the principal wire above or below, either incisal to or gingival to the brackets, depending on what direction we want to push the teeth. All right. And then we kind of ligate the main stabilization wire to the arch wire. So here we go. This is what it looks like. When I say take a segment of wire from the segment of the wire you would normally use for your stabilization wire, if you cut wire from back here, the wire doesn't have much curvature in it. This wire up in this area is much more curved. Don't cut wire back in this area and use it for your stabilization wire. Use the curved part of a wire. So you have to cut new wire. Here's an example of a case where the doctor didn't do that. The doctor used his stabilization wire and piggybacked incisal to the lower incisors. And when the doctor did that, this wire is a very, very straight wire. It doesn't have any curvature in it. And then you end up with this. See the very flat look of these incisors? No rounding out. The principal arch wire is rounded out, but the stabilization wire is flat across. So make sure you use a rounded portion of wire when you're piggybacking. Now, when we piggyback to close an anterior open bite, the idea is that the wire will deflect above the brackets of the incisors and then go back down. And as the wire memory recovers, the teeth are going to then extrude, and it's going to close the open bite. If you haven't taken the L2 course, write this down, or remember this. As teeth extrude, they retrocline, they tip back. As teeth extrude, they retrocline. So if we're going to extrude those upper incisors, they're going to tip back. So what are we required to have? We're required to have overjet. We've got to have overjet for the upper incisors to come down, because the upper incisors aren't going to come straight down. They're going to come down and back. And when they do, they can bump the lower incisors. So sometimes to get your piggyback technique to work, you've got to make sure and have enough overjet that this will occur. On the other hand, on the lower arch, if you were piggybacking gingival to the lower incisors, that probably wouldn't be so much an issue because as they extrude, they would tip lingually. Okay, both of them would tip lingually. The teeth that extrude, both extrude and retrocline, they tip lingually. Equal and opposite, teeth that are intruded tip facially. Okay, they procline. So here we have elastics on this. Now these are triangular elastics. I don't use triangular elastics often, but those are triangular elastics that also help in closing an open bite. So so we have elastics and we also have pop bends to close an open bite. So pop bends, you know how that work. We have intrusional and extrusional bends. All right. There are really two main elastics that we use, 3/8 and 3/16. 3/8 is when I'm using a large number of teeth, usually 4 or more teeth, usually 6 teeth. And 3/16 inch elastics for 2 to 4 teeth. I will use 1/8 inch elastics, typically canine to canine elastics. They're called vertical when it's from one tooth to another tooth. Elastics are worn 24/7 except for when they eat or when they brush their teeth. So they're going to change their elastics 2, 3, 4, 5 times a day. They need to be compliant. I have my patients take their cell phone out and we take a selfie for them with their cell phone so they can see how their elastics look. So when they go home, they know how to configure it and they're not wondering. They have a picture to refer to. Anterior box elastics are fine. There's some pitfalls with anterior box elastics. One is that they can irritate the tissue, the papilla. The other is, remember, as teeth extrude, there's going to be lingual tipping. So you got to do IPR because they're going to move lingually. They should start to bunch or crowd on you. And then we'll talk about focus elastics just a little bit before we quit. We're all familiar with Kobe hooks. Kobe hooks you learned about in the L1 class. We use Kobe hooks for placing elastics on anterior teeth, other than canines, laterals and centrals. So these are vertical canine elastics. Vertical canine elastics are great to prevent our bites from opening up. When you have a crowded case, crowded upper and lower teeth, but not much overbite, the bite will tend to open up on you as the case is treated. So you can use canine elastics during treatment to keep that from occurring. These are vertical canine elastics. Those would be 1/8 inch elastics. The anterior box looks like this. It's a box that goes around all the anterior teeth. You can see how it's going to tip the teeth up on the lower and back and down and back on the upper teeth. So they're going to retrocline. But you can also see the potential for papilla being irritated. We don't like to irritate the papilla. This is a focused elastic, focused in that it goes from lateral to lateral. So there you see the use of the Kobe hooks that we use. Remember, the Kobe hooks are placed on underneath the wire. The Kobe hooks go on before the wire. All the time, put long ties and Kobe hooks on before the wire goes in. All right. Now, again, these are triangular elastics used in combination with piggybacking. All right, and that's fine. That works well. But this is my favorite elastic. The way I correct open bites is with piggybacking and with inverted V elastics. You can see the direction of pressure is much greater because the elastic's doubled up. I'm really wanting to extrude that upper arch. I'm really wanting to pull those upper teeth down. I'll use an inverted V on each side along with piggybacking. All right. Then there's the U-shape elastics. U-shape elastics are like this. It's the same thing as the inverted V, okay, or the V-shape elastic, but this case it's a U-shape. Does the same thing, it just spread out to look more like a U, all right? In this case, it's used, focused on trying to extrude and retract the lower teeth. So as those lower teeth retract, they will extrude, and so overjet will be gained as the open bite's closed. Again, though, look at the papilla. You have to be careful. Those papilla can get really irritated. So I don't use these a lot. This would be the inverted U, okay, where we're trying to pull down on the upper teeth. Again, see the way the papilla can be irritated by the elastic. So then we can also have extrusional movement just in certain areas where we have an open bite in one area and we want to just run the wire underneath the brackets. Remember, as the wires run underneath the brackets, those teeth will move up, and as they move up, they'll tip lingually. They're going to retrocline on you as they move up. So we can piggyback anywhere. We can piggyback an individual tooth to move it up. But remember, as the tooth moves up, it's going to tip lingually. All right. This is one of my patients, Pia. She's a really sweet lady. She, back when I didn't realize what I should have done here, I'll tell you what I should have done. She didn't like what she looked in photos. Her son was getting married. She wanted to look better in her photos. What she has is a lot of crowding, upper and lower. Not an extraction case. because of the amount of crowding both arches. But what I know now is when arches round out, that means the teeth are going to procline. Okay, as they procline, they go up, so the bite's going to open on me. I would have been smart to start this whole case and do it with canine elastics on. If I had canine elastics on, the bite wouldn't have opened on me. But partway into treatment, I noticed there we were in that upper picture, the bite's starting to open up on me a little bit. I didn't have any overbite there, and I got really concerned about it. So I went back and I attached Kobe hooks on her lateral incisors, and we did anterior box elastics on her. And this was earlier in my career, but the anterior box elastics, as you can see, closed the bite down very well. I finished them up. I got her lower braces off, and I had her right before I finished them. I had her in a power train on the upper arch and closed everything right down. It got her a nice overbite, nice overjet, and the case finished off quite nicely. So she was surely happy. So again, piggybacking can be used to close the anterior open bite. Piggybacking in combination with elastics. In this case, these would be inverted V elastics, and you would leave the piggyback like that in place while you do the inverted V elastic to help close things down. You just have to have enough overjet for that to occur. Then sometimes I get real creative. Sometimes I throw all these elastics in. I know that looks crazy, but this case was finishing up, and so I had the posterior box elastics, and I did an anterior elastic, and didn't even need Kobe hooks. I cut a little groove in the top of her upper brackets to where I was able to pull those down. This is a really pretty case. I'm trying to have it published, but it's a really pretty case of how this case finished. So get creative with your elastics. Elastics are a great way to close the open bites. Now I said I'd share another trick with you, and that's how to keep it closed. We're going to place the fixed bonded retainer when we close an open bite. We all know that. Okay, the belt and suspenders approach, bonded and removable retainers. Well, you can also make a little notch in your retainer there. You can see where the little red arrow is. Okay, just enough of a notch there that when I make my Essex locks into that, like the little green arrow on the left. And so it's not that pointed. You can see how it looks. And my Essex locks into that, and that helps to prevent that open bite from relapsing. So remember, closing open bites, it's a lot to cover. I know that the amount of time, and we're about out of time, there's a lot to cover, and I want you to see it. So dual retention for life when closing those open bites. Okay, now, Mayor, do you want to take over at this point, or would you like for me to continue?
Dr. Haney, you're doing great, actually. I think it's great if you just want to talk a little bit about what we're about to show them. Yeah, I'll add if I want to add a point here.
All right, feel free to jump in. Those of you, if you're new to Confidex or haven't seen Confidex, well, it's wonderful. Most of the new providers, of course, are seeing Confidex or been introduced to it. Obviously, it's a very easy and predictable way to get a digital bracket placement and the aid and help of orthodontists and month-to-month treatment plans and digital bracket placement, STL files. You get to see everything. You get to approve your bracket positions. And we've had the 3D simulation we were able to show our patients in the past. And it's a great way to sell cases as well. But now, today, those of you who are online, you get to see the new Ortho Viewer. I've gotten to see it, and it's absolutely incredible. I'm really excited about this. Thank you, 6 Month Smiles. I think my patients are going to love this. But they have a web-based viewer now. I'm going to show it to you in just a second, but I'm going to read about it a little bit. But you can view from any angle now. You can zoom in and out. You can take brackets on and off for the patients. It looks very similar to what you see with some of the other aligner companies and their viewers. It's certainly more engaging because it looks very realistic to the patient. You can email this to your patients. You can pause it, rewind it, go frame to frame, fast forward it. You can take the models apart. You can look at the upper arch, the lower arch. You can look from the left, from the right. It's just a high quality presentation. So are you ready to see it? That's what it looks like. Now I'm going to close screens out and I'm going to switch over the internet. I'm going to play this for you so you can see it. So I'm going to escape from here for a second. And I'm going to pull up viewer here. And we're going to see what this looks like. If I can get my mouse to work. Here we go. And here it comes. So you're dealing with my slow internet right now, but I have this up and ready to show you, so it should come up any second. Hang in there. Here we are. All right, now we'll go full screen with this where you can see it. All right, now this is the new 6 Month Smiles viewer, and I want you to see how this works. You can see the little options up here in the upper right, where I've just got the lower arch selected right now. You can select either arch. You can select lower. You can select upper. Now it has braces or brackets on. I can switch over and look at a compound view. I can rotate this around. I can play it month to month. I can play out the movement. I'm doing that right now for you. You can see the brackets, how they're moving the teeth. I'll give us a different view so you can see that. I'm just playing with this online live for you so you can see it, to see what it looks like. So this can have, you can take the brackets off. You can show this with or without brackets. All right. You can look at the upper or the lower. You can look at it from the occlusal. You can pause it. You can go frame to frame, whatever you want to do. We'll take another view. We'll look at the right lateral view if you want to look at that. We can look here at the left lateral view. We can look here at the straight on view. Here we are right there. And then we can take just the lower arch, the upper arch, or just the lower arch. We can take this back to the very start now. By clicking here, we can go one frame at a time, and it'll go back to the very start. Or I can just place my button, my little indicator here. It will take me back to the very start. And then I can click play, and you can see the teeth, how they're rotated. You can show that to your patient with or without the brackets on, and you can watch it play now. That's phenomenal. That's so much better than what we had before. We can show the patients exactly what to expect on month 1, 2, 3, 4, 5, 6. It'll play over and over. So we can pause this, we can show them any view we want to see, and it's very realistic looking. They can relate to this, and they can see. You can email this to them if they haven't accepted treatment, and they see this, they're like, wow, that's what my teeth are going to look like. And whether you have the brackets on or off, if we go into this view and we have the brackets off, my goodness, it'd be really nice for them to see how that plays out and how their profile looks. I think that the patient would be thrilled to see how those teeth derotate. This has the brackets on. Go ahead, Amir.
Yeah, try to use your mouse to ring the ring that's on your mouse, and you should be able to zoom in and out as well. There we go.
This just gets cooler every minute.
And if you hold the right click down and try to rotate it, it should rotate to any angle you want.
See if I can do that. Pull down.
Just hold the right mouse button down and
right.
Yeah.
Oh yeah. Oh
there
wow. I'm having fun here. This is great. Oh my gosh.
So just for the audience, I think this is pretty cool. It's taken us a lot of time to develop this. This is all online, so it does not require any software. And when Dr. Haney said you can email this to your patient, what he means is that you can send him a link, just a link to a website, and that should allow them to view this viewer and do all the cool things that Dr. Haney is doing with this simulation right now for their own, obviously for their own case. Thank you. So this is an improvement that's coming to Confidex sometime in the next few weeks. We don't have it today, but wanted to share this exciting improvement to Confidex. So it'll be coming to your Confidex cases either later this month in November, or certainly in cases that you submit in December onwards.
That's fantastic. All right, I'm going to let you share this with them now, if you would.
Okay.
Hello, Dr. Haney. It's Stephen from 6 Month Smiles here, and what a fantastic presentation that was today. And that ortho viewer, I want to say it stole your thunder, but wow, what an awesome advancement that's going to be, right? But here's one other thing that we have today that I think is absolutely spectacular. We are starting our Black Friday sale. As soon as this webinar is over, you'll be able to get the lowest prices of the year on courses, supplies, and we're offering things that we don't generally sell unless you're at a course. So let me go through a couple of the offers real quick. Level 2 training, taught by Dr. Brooks Haney over here in the States, Dr. Jazz Gill over in the UK. This is the lowest price. It's over 50% off. Normally, a course would cost you $27.50 in the US, and I believe 2,200 pounds in the UK. So this is a good discount at $12.99 in the US, and I believe it is £9.99 for the UK. So it's a great way. We only have 6 of those courses a year, 2 in the UK for in the United States, they do sell out. So booking today would be to your advantage. Now we're going down the line here. You'll see a 6-pack of Confidex e-vouchers. Thank you. So what that is, that's actually 3 cases that's 6 cases pre-purchased. That's at a 20% discount. So if you are maybe a provider in that silver or gold level status where you're not earning a discount for every case you do, this is a great way to help you move up the ladder to achieve those discounts while sustaining a discount along the way. So if you have team members, some family members, maybe you wanted to do some additional cases before 2018 ended, this would be a great way to boost your production through the end of the year. So that's only available in the e-commerce store till the 26th, and then you can purchase them at the course. That's the only place you can get them. And then last but not least, an old favorite is 10% off all tools and supplies. So whatever you order, whether it's a starter package or whether you want to just get some backup brackets and wires in the e-commerce store, you can get that 10% off this week only. Usually we pick and choose the items. Everything is on the table.
Yeah.
And so why level 2? Why would you want to attend the level 2 course? Of course, level 2 builds upon the concepts we talked about today. It increases your clinical knowledge and confidence. Providers who take level 2 see faster results, treat more patients, and make their patients happy and grow their practice. You can learn from, of course, our clinical instructors, as mentioned, Dr. Brooks Haney and Dr. Jaswinder Gill in the UK. Those are the upcoming courses. I will always say Vegas is very well attended. We'll actually probably be doing some filming there. It should be a very fun course. London is always great. Boca Raton, a great destination location for our UK friends as well. And of course, Dallas, that is where 6 Month Smiles headquarters is. So you do have the benefit of sometimes accessing team members who do not normally travel to courses. So we can talk about marketing or some other things that we might not get to. So we would love to see you at those courses. With only 6 on the table and this great sale, it will sell out. I am just forewarning you now.
Is that the promo code down there, Friday L2?
Yes, sir. It sure is. I mean, that's kind of the most important part there, right? So yes, on checkout, use Friday L2 and you will get that $12.99 or $9.99 discounted rate on your L2 course.
Great. Well, that's fantastic. This is fun. This is a fun day. The Black Friday, I like it. It's cool. That's wonderful. I really am excited about this viewer. I have to thank all of you there that on the 6 Month Smile side, that viewer that you created, heaven. That's going to be wonderful.
Well, Dr. Haney, thank you for your vote of confidence in Confidex and all the things that you do for us. I don't know if the viewers stole the show compared to all the interesting things you showed us with the elastics. Boy, some of those configurations are pretty wild. And we've had a few comments of people trying, who want to come to level 2. So what I'll say to them is that if you love this stuff as much as we do and you enjoyed this short webinar, you can get 2 more days of that with a level 2 course. And of course, the ones in the US are hosted by Dr. Haney. And if you prefer this to be done with an English accent, you're welcome to come to London. And Dr. Jas Gill will present similar content in London, England as well. And the dates are already there, as you can see. Okay, so just some logistics. Is this the end, Dr. Haney? Is that the last slide you have?
That's it.
Oh,
Yep.
right. Fantastic. So just some logistics. We do have a list of folks that attended. You will get your CE CPD credits in a few days, mailed to you. The presentation is recorded, and we will send you a link in the next few days so you can watch it. We're going to send a link today, Stephen tells me. That's even better. So you can watch this presentation in its entirety at your convenience. Some people experience some dropout issues, so hopefully you'll be able to watch this presentation at your leisure without those issues as such. Well, before I cede the floor back to Dr. Haney, let me be the first one to thank all the attendees for attending. We had several hundred of you come in here. Thanks for all your questions as well. We are here 24/7 on the forum, with email, chat, and so on. Keep the engagement going. Let the questions come. Let us help you. as well as Dr. Haney. Again, once again, from the bottom of our heart, I want to thank you for your passion and your devotion, and certainly your time in not only putting this fantastic presentation together, but also sharing what you know with us. So once again, a big thank you from all of us. So Dr. Haney, you want to say something else? So then we'll wrap this up.
No, thank you. I'm ready to wrap it up. I appreciate it.
Yeah. Great, guys. So everybody, have a great. I know there's one more day left till the weekend is here, but nevertheless, happy weekend for folks in the United States. A wonderful, wonderful Thanksgiving to you, to all of you. We will send you the codes and the specials again, but you're the first ones to see it for our Black Friday event. You'll be getting that again from us shortly, so do take advantage of those. Look forward to seeing you at another 6 Month Smiles course, and keep the cases coming. And all the best. Bye bye now.
Bye-bye.